This video is going to be on the nerves of the upper limb. And I always suggest that when you watch these videos, you follow along with first aid or with my notes, or at least with Google Images. And in particular, this video is very important to follow along with pictures, because if you can see the pictures of the nerves and see where it runs along, where it courses, it makes it very easy to understand them. Okay? So make sure you have pictures of the nerves while you're watching these videos, and it makes things easier to remember. We're going to talk about the nerves of the upper limb. And the nerves of the upper limb, they all branch from this bundle near your neck, from around C5 to T1. This bundle of nerves, we call it your brachial plexus. And your brachial plexus will come together and kind of spread out and eventually become 5 individual nerves that innervate your upper limb. And those 5 nerves are going to be your axillary, musculocutaneous, radial, median, and ulnar. We'll start with axillary first. If you see a picture of the axillary nerve, you'll see that if this is your humerus and this is your shoulder joint, the nerve will kind of course down and end pretty high up around the shoulder. And that's exactly what it innervates. It innervates your shoulder. And because it kind of courses higher up, it takes its origin from pretty high roots, so C5, C6. And it innervates your shoulder, your deltoids, and the sensation around it. So, all right, shoulder, sensation, and power. Now you see it kind of circles around the neck of your humerus. So if you have fractures here or if you have dislocations, you can damage this nerve. So, all right, damage from fracture, dislocation. And if you damage that nerve, then what do you think is going to happen? You'll no longer innervate it. You're going to have loss of sensation. You're going to have weakness. It'll start to atrophy and flatten. So atrophy, weakness. You won't be able to do what your deltoids do. What do your deltoids do? Your deltoids abduct your arm. You'll lose that ability if you knock out that nerve. That's your axillary nerve. Easy enough, right? Let's move on to your musculocutaneous. Your musculocutaneous nerve will course down your biceps, and then once it gets to around your bicep region, it'll wrap around the back laterally. It'll wrap around laterally. So it courses down the biceps, wraps around laterally, and that's exactly what it innervates. So innervate your biceps and then your lateral forearm. Lateral forearm. And the roots, it's just one root down, so C5 to C7. I always remember musculocutaneous is innervating your biceps because when you ask someone to flex their muscles, they always do this. It's like the universal signs of flexing your muscle, and that's flexing your biceps. So musculocutaneous innervates your bicep. And if you have damaged this nerve, what do you think will show? Well, you won't be able to do what your biceps do. Your biceps flex your arm, and it also supinates your arm. So you cannot flex, you cannot supinate. So I'll say loss of flexion, supination. You'll also have loss of sensation on your lateral forearm. Loss of sensation, lateral forearm. Done with that. That wasn't too bad. Radial nerve will spiral basically throughout your arm. It's kind of cool. And I always think because it kind of spirals throughout your arm, it takes root from all your nerve roots. So it goes from C5 all the way to T1. So C5, T1 all contribute to your radial nerve. And your radial nerve will start kind of like your musculocutaneous, go down your bicep, but at the mid of your humerus, it'll spiral to the back. And once it curls to the back, it'll innervate a big muscle in the back of here called your triceps. These extend your arms, and in fact, they'll innervate all your extensors. This is sometimes called the great extensor nerve. The radial is a great extensor nerve because it innervates all your extensors. And it'll keep going on the back and innervate the posterior arm and also the dorsal part of your hand. Dorsal part of your hand. So let me write this down. So it goes from your middle of your humerus. I'll say spiral from middle humerus to back of arm, innervating the extensors. plus sensation of your dorsal hand. Now, what can go wrong? Well, like I said, it spirals from the middle of your humerus. So if you have mid-shaft humeral fractures, if you fracture your humerus right in the middle where it spirals, you can damage that. So damage from mid-shaft fractures. Or you can compress it with crutches if you put your crutch right where it spirals. Or sometimes we call it Saturday night palsy, where you like rest your arm over something. You can compress it and you can have radial nerve damage. So just right compression. What do you think will show? If it innervates all your extensors and keeps your arm extended, keeps it straight out, and you can no longer extend your elbow, then your elbow will flex. If you can no longer extend your wrist, then your wrist will flex. And we call that wrist route. Yeah, you can't extend. We call that wrist route. So damage equals wrist route. That's the motor aspect. How about the sensation? You'll lose sensation, especially in the dorsal of your hand. Sometimes we test it just by testing the anatomical snuff box, yeah? It's the easiest way to test the radial nerve sensation. So I'll just write snuff box. And you know I'm talking about you lose sensation on the dorsal of your hand. Snuff box sensation. Hopefully that's easy enough. The last two is your median and your ulnar nerve. Your median and your ulnar nerve, I always put together. Your median nerve will course down in the middle like everything else, but as opposed to everything else, it doesn't spiral. It just keeps coursing all the way down your hand. Your ulnar nerve does the same thing, but it's lower. It's probably the lowest set nerve. It's the most medial nerve. So it's the lowest. So it kind of courses all the way down to the bottom, to the most medial, to the lowest part of your hand. That's what it does. So median, I said, courses right in the middle, right down your arm. And the nerve roots for your median nerve is going to be your C5, T1. And it courses down your arm, down arm. And while it courses, it is very close to your epicondyle. And if you have an epicondyle fracture or a fracture above your epicondyle, we call that supra-epicondyle fracture, then you can damage your median nerve. So our epicondyle / supracondylar fracture can damage it. And we said that your ulnar nerve is the lowest lying nerve, goes down to the lowest, most medial part of your arm. Because it's lower, it will take nerve roots from the lowest it can, so CAT1. And as it courses down the lower part of your arm, it courses through your medial epicondyle. And if you fracture your medial epicondyle or you bump your medial epicondyle, don't you feel your fingers kind of tingling? We call that hitting your funny bone. So that's your ulnar nerve. All right, medial epicondyle. Medial epicondyle. And as these two run down your forearm, as they run down your forearm, they will innervate your flexors, flexing your fingers. Forearm equals flexor. But they don't just stop at your forearm, they keep going more distal, all the way down to your hand. And your median, I need to put this down. Your median, because it sits higher up, will innervate your first 3.5 fingers. Your ulnar, because it's the lowest lying nerve, will innervate your last 1.5 fingers. Okay? And so, all right, sensation for your median is the first 3.5. Sensation for your ulnar is the last 1.5. And when it courses down this distal part, this last part, it will innervate your extensors. Distal equals extensors. So we said your forearm part, your proximal part, your upper part was your flexors. Proximal equals flexors. And we said the bottom part, your distal part, is your extensors, and that's very important to know. Why does it innervate your extensors? Well, it innervates actually your lumbricals. And your lumbricals, I want you to do this with me. Your lumbricals, flex your MIP and extend your DIP, extend your fingers. And that extension is what we're really concerned about, that extension of your finger. So again, your lumbricals, flex your MIP, extend your DIP. Does this. So distally, it will extend your fingers. That's very important, you know. So let's just try and make sure we understand it all. If a patient comes in, lost the sensation in his first 3 fingers, then you know it's the median nerve. If it's a problem up here, proximally, it's a problem with flexing. So you'll tell the patient, can you flex your fingers? And they won't be able to flex their first 3 fingers. They'll go like this. If it's a problem distally, it's a problem with extension. Tell the patient to extend their fingers, and they won't be able to extend their first 3 fingers. They'll go like this. Understand? If a patient comes in, lost the sensation on their bottom 1.5 fingers, you know it's the ulnar nerve. If it's a problem up here proximally, then it's a problem with their flexors. The fingers of their ulnar nerve can't flex. So you tell them to flex, and they'll go like this. And the last 2 fingers won't be able to flex, will they? If it's a problem distally, then they won't be able to extend these fingers. So you tell them, extend your fingers, and they'll go like this. These 2 can't extend. Understand, very important that you understand. If there's a problem up here, problem with flexion. If there's a problem down here, distally, it's a problem with extension. All right, very important you know that. Those are your 5 singular nerves, and what can go wrong if you damage one of those nerves? Can you damage more than one of those nerves? Yeah, sure, you can damage a whole bunch of them. Let's see what can go wrong if you damage a bunch of these nerves. One of the classic ways you can damage a bunch of these nerves is through delivery of a baby. Let's say it's a very complicated delivery, the baby's really big, and you try and pull the baby out of the vaginal canal, and you pull the neck, and you pull the head, and you kind of tear the upper trunks. We call this Erb's palsy. This is due to damage in the upper trunks, mainly C5, C6. And it can damage a lot of nerves, but clinically it appears to damage the axillary and the musculocutaneous. What does the axillary nerve do again? Innervates your deltoids. Helps you abduct your arm. If you can't abduct your arm is stuck to your side. Can't abduct. What does your musculocutaneous nerve do? Innervates your biceps, flex your arm. So you can't flex your arm is extended. Can't flex. Extended. Some minor muscles it also seems to damage. It seems to damage your rotator cuff muscles, including your supraspinatus and your infraspinatus. This is a MSK throwback. What do your supraspinatus and your infraspinatus do? Your supraspinatus also abducts, so these 2 go together. Your infraspinatus laterally rotates your arm. If you can't do that, then it's medially rotated. Yeah, so the culmination of which, you won't be able to abduct your arms stuck to your side, you won't be able to flex your arms extended, you won't be able to laterally rotate so your arm is medially rotated, and your arms will look like this. Yeah, the baby will be able to move this arm, and then one arm is just kind of like stuck to the side, kind of like this. That is Erb's palsy. That's damage to your upper roots. How about your lower roots? Well, let's just take again a very complicated pregnancy, and maybe their arm's stuck out. So you try and pull the baby out of the vaginal canal, and you pull on their arm, and you just stretch the living crap out of these lower roots. Or another example, a kid is climbing a tree and falls, and they try and brace their fall. They'll grab onto a branch and they'll pull the living crap out of their lower roots. So that's another way they can do it, but whatever the case, we'll call it Klumpke palsy. Klumpke palsy. And this is damage to your lower roots, especially C8, T1, and this damages your innervation to your lumbricals. What do your lumbricals do again? Your lumbricals, found this away. Your lumbricals flex your MIP, extend your DIP. If you can't do that, if you can't flex your MIP, then your MIP will be extended. If you can't extend your DIP, then your DIP will be flexed. We call that claw hand. Claw hand. Damage to hair causes claw hand. There's something very similar to Klumpke palsy. It's called thoracic outlet syndrome. Thoracic outlet syndrome. You see, these lower roots will go under your cervical ribs, and also your subclavian will go under your cervical rib. Subclavian, vessels. And if you have something wrong with your cervical rib, or if you have a tumor, or you have a mass, then it'll compress your lower roots and you'll have your claw hand, but it'll also compress your subclavian vessels. So the way you can differentiate the two is, one, they'll both have claw hand, but thoracic outlet syndrome compresses those vessels. You'll have signs of ischemia. It might turn blue. All right, that's not Klumpke palsy. That's something else. There's something wrong with the blood vessel, and that's a dead giveaway for thoracic outlet syndrome. All right, that does it for your upper limb neuro. Again, look at pictures. It makes things very, very easy. Or look at my notes, or look at first aid, Google image, whatever. Makes things very easy. Just do that, and I think you should be good. Thanks.